Attendees are in listen-only mode.
Good afternoon. We're just starting. Almost everybody is on. And today we're presenting clinical tools for nutritional pathways involving hospitals, older adults. It is a result of a TVN-funded Catalyst grant with Heather Keller. Before we start, I have a few things to go over, if my slides would actually change. So to let everyone know, the webinar and the slides will be on our website. There might be a delay. Normally it's 1 to 2 days before we put the slides up and the actual webinar. But because we are in transition to change our name from TVN to the Canadian Frailty Network, it will take a few days. So I guess I should go first over the research update. Right now we have a summer student award in process. Due this Thursday is the intent to apply, and we are increasing the number of awards from 10 to 20, and the applications are due March 10th. 2015 Catalyst and Transformative Research Grants, they're in the review process currently, and the results will be announced early April. There is a new one-year fellowship that started January 1st. The announcements will go up on our website later this month, and we also have the ACE Collaborative, and the announcements on that funded acute care teams will also be in late March. Upcoming webinars, we have one coming up March 2nd, March 23rd, and April 6th. Because a lot of the projects are coming near end, and there are a lot of projects, we are going to attempt to do 2 a month. So please register. Right now it still says TVN, and everything will get directed from TVN to CFN, but again, probably by next week. Please submit your questions online during the webinar. We'll answer as many as we can. And again, it's being recorded, so it will be posted early next week. So our presenter today is Heather Keller. She has her PhD in epidemiology from the University of Western Ontario and has her master's in nutrition from McGill University. She's a professor in the Department of Kinesiology at the University of Waterloo and the Schlegel Research Chair in Nutrition and Aging. She is also the chair of the Canadian Malnutrition Task Force, leading interprofessional team focused on improving identification and treatment of malnutrition in acute care settings. Her research interests span community and institutional sectors and include nutrition risk screening, assessment, and nutrition intervention for seniors in general and seniors with dementia.
Great, thanks very much, Carol. And can everybody see my slides all right? Carol, can you see the slides? We're all set to go?
Yep, I can see your slides.
Great.
Go ahead, Heather.
Okay, thanks very much. So I'm just going to start here. So our learning objectives today are to understand how evidence and consensus-based methods can be used in tandem to create a best practice. Also appreciate the iterative process required for clinical tool development. I'll be describing 2 clinical tools specifically that went through considerable development in addition to the pathway, which was developed with our TVN funding. And finally, to be informed of the content of these clinical tools in the pathway and how they may be used in practice and in research. So in terms of just moving forward here, I'm having a problem getting my slides moving. Sorry. There we are. So in terms of an outline for today, why do we need to advance nutrition care in Canadian hospitals? I'm going to present some details and results from the nutrition care in Canadian hospitals study that was conducted a few years ago, and then go into the development and testing of 3 tools. One is a pathway, the integrated nutrition pathway for acute care, and the My Meal Intake tool and the Mealtime Audit tool that were created to support the use of the pathway in clinical practice. And all of this work has been funded by the TVN Catalyst grant that I received in 2014. The next steps post-TVN Catalyst grant are also going to be described in our current study called the More to Eat study. And hopefully we'll have a few minutes for discussion at the end as well. So first off, the prevalence of malnutrition in Canada is actually quite high. What I've shown here on this slide is data from the Nutrition Care in Canadian Hospitals study that was conducted by the Canadian Malnutrition Task Force between 2010 and 2013. And what I've done here is segregated the sample by those under the age of 65 years and those over the age of 65 years. We use something called subjective global assessment, which is a standardized method to identify basically those who have mild to moderate or severe malnutrition or who are well nourished. And so on the pie graphs, you can see that the light green portion is the well nourished group, the gray is the moderate malnourished group, and the dark green is severe malnutrition. And what you can also see from this slide is that much of the malnutrition prevalence that we see in hospital is driven by the older adult, with about 45% of those over the age of 65 being malnourished, either moderately or severely. And this is a smaller proportion in those under the age of 65, where it's more like 34%. So in addition to malnutrition, and that's on admission to the hospital sector, we also identified in this large study over 1,000 patients that food intake varied. Specifically, we identified during the first week of admission for all of the patients that were in the study, they self-identified how they were eating their meal at a single lunchtime or supper time, and we did that over 2 or 3 days of the first week. Those that were well nourished on admission generally ate the food quite well. So you can see 75% ate 50% or more of their tray during the first week, whereas only 25% ate less than 50% of the food during that week. Those that had malnutrition without inflammation, so they had a C-reactive protein that was normal, also ate the food that was being provided to them. However, when we had patients with malnutrition as well as inflammation, this group was not as likely to eat the tray. And so this is a group that we're quite concerned about because the challenges of poor appetite and not feeling well while in hospital lead to poor food intake and potentially can delay the length of stay and recovery of the patient. What we also saw in this data is that about a third of patients ate less than 50% of their tray in the first week of admission. So this is quite a significant problem. You think 1 in 3 patients are not eating half of what we're providing to them. Additionally, about 11% were kept NPO, or no food by mouth, for more than 3 days. This is also considered a problem in thinking about recovery of the patients and poor food intake. We also in this study identified patient-reported difficulties with eating. And this is done through a survey at the discharge, time of discharge by the patients. You can see quite a variety of barriers to food intake occurring in this sample. For example, those who missed a meal and were not given food to replace it was almost 70% of our patients in the study. Those who did not get help when they needed that help was about 42%. 42% were interrupted by staff during their mealtime, and another 39% had other disruptions to the meal, such as noise or cleaning that was happening in the room, for example. And finally, things like opening the packages on the tray, about 30% had this challenge, and 20% couldn't even reach their meal. The tray was away from their bedside or outside of their room, and they couldn't get at it. So there's significant problems around access to food in the hospital that can lead to what we call iatrogenic malnutrition as well. If we look at the data that supports what predicts the length of stay, we wanted to determine if malnutrition and food intake independently of age and gender and diagnoses was an important variable in saying that the recovery was delayed and the length of stay was longer for patients. Here we use the Cox proportional hazards to identify this. And so just to walk you through the stats here, a number that is above 1 means this predicted a shorter length of stay, whereas a number that is less than 1 meant that the person had a longer length of stay. And so what you can see here is that malnutrition, either moderate malnutrition, which is SGA-B, or severe malnutrition, which is SGA-C, based on a standardized assessment we did at admission, was associated with a longer length of stay and was significant. Hand grip, a higher hand grip strength, which means less frailty, better nutritional status, better function, predicted a shorter length of stay. And again, this was significant. Receiving nutrition support at admission also predicted a longer length of stay. As well, food intake, less than 50% of the tray during the first week, also predicted a longer length of stay. Male gender, living with others in the community setting, also predicted longer lengths of stay, as did the comorbidity, number of diagnoses, and number of medications. These, however, this data actually shows, however, that these highlighted ones, malnutrition, hand grip strength, nutrition support, and food intake, were quite significant and independent predictors. We adjusted for things like cancer, the type of unit the patient was on, whether it was medical or surgical unit, their comorbidity based on Charlson Comorbidity Index, education, age, having a dietitian visit, having no food by mouth for 3 or more days, pre-admission weight loss, and BMI at admission. And despite controlling for all these factors, still malnutrition on its own and food intake less than 50% on its own predicted length of stay. So just to reiterate here, those who are well nourished and who also do not eat the tray had a longer length of stay. So we also looked at the data in terms of who saw a dietitian during their stay. And dietitians are the specialists in the healthcare environment, and acute care specifically, that can address malnutrition. We want to determine who was seeing the dietitian and what were the characteristics that led to a dietitian consult. So we found that type of hospital, diet technician, surgery did not influence if a dietitian visit occurred. And only one of the 18 hospitals had a standardized screening program that was not fully linked to the RD involvement or consultation. In our analysis of these over 1,000 patients, only 23% saw a dietitian. 45% of those people that did see the dietitian were well nourished using the subjective global assessment, whereas 36% were moderately malnourished and 19% were severely malnourished. When we looked at the analysis in terms of who was being missed, 3/4 of those that were moderately malnourished did not see a dietitian, and 60% of those that were severely malnourished were missed. So this means our ad hoc referral processes that we're using in acute care hospitals are not working in terms of identifying malnourished patients. We also looked at this in terms of a regression analysis to find out what were the independent predictors of seeing a dietitian. And so we looked at this in 2 ways. First, those referrals that happen in the first 3 days. Likely this is protocols and mechanisms based on diagnoses and other factors such as that on admission that lead to nursing staff or a physician to identify a person who needs an RD consult. Whereas after 4 days, we hypothesize that it might be other things going on, such as the person having more complexity or comorbidity that's leading to their longer length of stay that leads to dietitian involvement. And we did find that that was borne out in this analysis. So if you look here again, this is a regression analysis. So each of these are independent predictors of each other. So we've controlled for, in essence, these various other variables. What we see here is what drove the dietitian consult was modified texture diet on admission or renal diet on admission. These people had high odds of seeing a dietitian. Also, those with metabolic disease also were more likely to see a dietitian. Older patients were less likely to see a dietitian. When we look at severe malnutrition, it was the only nutrition variable that came out in predicting a dietitian consult within the first 3 days. But you can see that the odds ratio is lower for this than it is for the other variables like modified texture and renal diet. After 4 days of admission, the severe malnutrition also triggered a dietitian consult, but again, the odds ratio is not as large as it is for other variables such as dysphagia during admission or constipation. So this tells us that what drives a dietitian consult at admission is diagnoses and diet textures or diet prescriptions as the patient is being admitted, and post-admission is complexity of the patient and comorbidities such as constipation and dysphagia that lead to a dietitian consult, and that malnutrition itself is not being recognized by the hospital staff who are referring to the dietitian. So this suggests to us that we need something better in place. We see from this data that was done in the Nutrition Care and Canadian Hospital study that malnutrition occurs in the community, and approximately 1 in 2 patients are coming in with some level of malnutrition. We also see from this data that malnutrition is being perpetuated by the hospital admission, specifically barriers to food intake, and so there is likely an iatrogenic component as well. We also know from this data that people who have malnutrition stay on average 2 days longer, and this costs approximately $2,000 more per malnourished patient as compared to a well-nourished patient. And this is then leading to about $2 billion per year for acute care hospitals in Canada. If we have 1 in 2 prevalence of malnutrition on admission, this means that we can't meet the needs of all of these patients coming through the acute care system in medical and surgical patients with our current system of care. Dietitians cannot be seeing half of the patients that are being admitted. Unfortunately, we don't have those resources. This means we need to change the culture of care and how we provide nutrition care in hospital. It suggests as well that we need to think about working differently. The entire team needs to be part of solving this problem. Everybody has a role to play in dealing with nutrition and nutrition care in hospital. All of our staff, family, and patients need to become food aware and treat food as medicine. The dietitian should be seen more as a specialist resource, positioned to train fellow colleagues in terms of other staff, but also to triage patients to other forms of care that can meet the needs of patients. We also need to think about connecting patients better to community services. I did not show you this data today, but we did find a significant proportion left the hospital and continue to lose weight post-discharge, which means we're not necessarily linking people up properly to community services that will help them to not be readmitted to hospital. And finally, we have to involve the patient and family as well in the monitoring and care process, because they're a significant part of the care program in acute care and post-discharge. So what does this solution potentially look like? Well, we think a new best practice is what's needed. Rather than the ad hoc process of referral to a dietitian when someone comes into hospital, we think something needs to be in place that's better. We need to think about looking at prior guidelines, and we did this and saw what was happening in terms of nutrition care. All of them identified that screening is a key best practice that needs to be put in place, as well as assessment post-identification of those at risk and treatment of those individuals. So that certainly is a best practice that's needed to move forward in Canada as well. However, none of these guidelines, when we looked at them, address barriers to food intake, like disturbances during the meal or being interrupted by staff during the mealtime. They also didn't specify how we are to monitor improvements in nutritional care during the patient's stay in hospital. As well, we looked at these guidelines, identified that there was no real sense of considering that a high prevalence is going to lead to positive screening and might overload the system in terms of overwhelming the care around a dietitian referral process. So again, if we think about 50% coming in malnourished, not all of those patients can see a dietitian for a full assessment that takes a significant amount of time and be followed on a caseload by a dietitian. And then finally, we also, when we looked at the literature, there was a lack of evidence for basic common sense practices, like you need to open trays for patients who are having challenges with opening packages, for example. This led us to then putting together our Catalyst Grant proposal, which was funded by Technology Evaluation for Elderly Network in 2014. Our primary purpose in this Catalyst grant was to develop the integrated nutrition pathway for acute care. So I'll explain that first, but we also had the secondary objectives of developing some clinical tools, which I'll also describe during this presentation, to support the integration of this pathway into acute care. So what is INPAC? It is an evidence-based algorithm for the detection, treatment, and monitoring of malnutrition amongst acute care medical and surgical patients. We developed it through consensus from leading Canadian experts, clinicians, and other stakeholders. It is meant to be a minimum standard, and if a hospital unit provides care above this minimum, we are encouraged to continue that high-quality practice. So how did we go about developing INPAC? We started with an environmental scan first off. There was a very influential guideline developed and put into the literature in 2011. So we decided to pick up our literature search from that point forward to 2014, so 3 years, and looked at the various key journal articles and did a lit search using key words, of course, to identify other influential manuscripts and documents that could say something about best practices with respect to nutrition care in hospital. We looked at organization websites, for example, ESPN and ASPN, which are two international organizations focusing on malnutrition and nutrition care in acute care hospitals. And we looked at a variety of policy documents that had been developed as well. From this, we developed a narrative review and understood what was being developed based on what was presented based on these other pathways, what were the common elements, and where there were gaps, and what we needed to potentially improve upon in developing a pathway for Canada. We also looked at the grey literature and expert opinion on better practices. For example, some of these organization websites talked about things such as red trays to be used for patients who had feeding difficulties and would alert staff, for example, to those patients who needed that help. We also put all of this material into a detailed background document on key practices that was then provided to our stakeholders for our next step. From this environmental scan and detailed background document, we developed a draft pathway of what we thought was better practices. This draft pathway and the detailed background document were provided to a stakeholder group in a modified Delphi process. It's modified because we first had a meeting to decide on what were the key questions and agree on the content and issues that we need to address in the pathway. And then we had 2 rounds of questions through a Delphi process, which was online, to develop consensus and ensure that the pathway was looking like we wanted it to be in terms of evidence towards the best practice. So at our stakeholder meeting, we basically had a one-day meeting. 60% of the people that were at this meeting in Toronto were frontline providers of care. We also had a research group, of course, that were part of the co-investigator group for the development of the INPAC. As I said, the key point of this exercise was to get agreement on what were the issues to be included in this pathway, what would be the activities that should be part of the pathway, such as screening at admission. We then, over the summer months of 2014, had 2 rounds of Delphi using an online survey protocol and methodology, which allowed individuals to anonymously rate their beliefs about these various activities and provided some qualitative comments about why they rated a certain activity in a certain way. For example, did they strongly agree that screening should be done at admission and who should be doing it in terms of staff role? That was completed by approximately 30 people during the summer of 2014. We found that we achieved consensus on 50% of items on that very first round. And consensus was when we had 80% or more of those 30 people saying that yes, they strongly agreed or agreed with the statement or question. Only 2 items in all of our questions did not achieve consensus. So we found this to be a very efficient method for delivering and determining consensus on the pathway. As a final step, we confirmed the pathway with our co-investigators. We then took that pathway into what we called a content validation or face validation phase. We took it to 4 diverse hospitals in focus groups and basically presented them with the draft algorithm and said, What do you think of this? Do you think it is best practice with respect to nutrition care in hospital? And then secondly, what would be the things we need to think about in terms of rolling this out and making it feasible in acute care? Overwhelmingly in those four focus groups, we identified that yes, this was best practice. The variety of staff who'd never seen this pathway before said, yes, this is what we should be doing. The question became how to do it, of course. And so they identified there would be some challenges in uptake in terms of various aspects of the pathway. We then took this pathway that went through that phase validation, that first phase with focus groups in hospitals, and took it back to stakeholder group this past April, so March of 2015. And we re-engaged our initial stakeholders and some new stakeholders and identified and tried to gain greater diversity in that stakeholder group. We specifically reviewed the guide or the pathway for feasibility and worked on terminology and a guidance document that could be used with the pathway. So now I want to walk you through what the pathway looks like and also the tools that we developed in addition to that support the pathway. So this is the INPAC as it stands. And so you can see that at admission, we're recommending that nutrition screening be done using the Canadian Nutrition Screening Tool. And I'll show you what that looks like in just a moment. If a person is not at risk based on the CNST, we recommend they receive level A care, which is standard care. I'll also walk you through that in just a moment, what that looks like. If someone is at risk for malnutrition, we then are recommending that subjective assessment be done. A reminder, this is a 10-minute standardized assessment that's done typically by a dietitian or other trained personnel in the hospital. The benefit of SGA is that it quickly tells you, is a person severely malnourished or mildly to moderately malnourished or well-nourished? If they're well-nourished, they would just receive level A care while in hospital. If they're mildly to moderately malnourished, we suggest that they receive level B or advanced nutrition care. This means the dietitian doesn't necessarily have to do anything more than lead them into the pathway of level B. And if this works, they don't need to do a full assessment. Whereas if they are significantly malnourished or severely malnourished, we recommend they receive specialized nutrition care, which immediately means a full assessment and more detailed care processes such as individualized diet prescription. A level B moves up to a level C if they are not eating well, despite having some standardized advanced nutrition care practices put in place. Similarly, a level A patient would move up to advanced care if they're not eating well within the first 3 days of admission. In addition to the pathways during acute care, we also have post-discharge, the idea that anybody who is identified to be malnourished during admission through the subjective assessment would have a post-discharge care process put into place. Here's the Canadian Nutrition Screening Tool, and you can see that it's 2 basic questions that do not require measurements. So nursing staff, for example, or a diet technician on admission could ask the patient, have you lost weight in the past 6 months without trying to lose this weight? So getting at the unintentional weight loss. And have you been eating less than usual for more than a week? If a patient says yes to both of these tools, that indicates the person is at nutrition risk and should go through the step of subjective assessment. This has been validated in our main study and in a sub-study that we conducted. And I can point you to Laporte, her paper that will describe that validation process. So if we go back to level A standard nutrition care, this is basic things that should happen in terms of best practice to make sure the patient is eating the food that's being provided to them. So for example, making sure the patient is well positioned, they can reach their tray, they have all the vision and dentation needs addressed, such as their dentures in and their glasses on, making sure that food's available and bedside tray is opened when they are providing the trays, packages opened, etc. So those basic things we should be doing for all patients to make sure they can eat the food that's being provided. We also recommend monitoring and reporting on food intake twice a week during admission. And if that food intake is low, then moving them up to level B. If a person is at risk, based on the CNST, we recommend subject global assessment being completed. I'm not going to go through this tool in detail at this point in time, but point you to the Canadian Malnutrition Task Force website, where you'll see a guidance document on how to use the subject global assessment. And CMTF also provides training for any clinical groups that would like to receive this. If a patient post SGA completion is identified to be moderately or mildly malnourished, we recommend a level B advanced nutrition care. This means that we continue with the standard nutrition care practices, such as opening up the tray, ensuring that their dentition and vision needs are being met, but also address other barriers to food intake and monitor food intake at least one meal per day. We also recommend that advanced nutrition practices be put in place, such as a nutrient or energy-dense diet, a liberalized diet, preferred foods, high energy or protein shakes or drinks, and or snacks available between meals. As you remember from some of the presentation material I presented at the beginning from the Nutrition Care Canadian Hospital study, many people who are undernourished will eat well if they're provided enough food. And so this group we're hoping will be met through advanced nutrition care practices. So if this group, though, doesn't eat well, so in terms of not eating well for a meal during a day, we would then suggest that they go up to what we call specialized nutrition care. And this is where we have, again, standard and advanced nutrition care practices in place, but then the dietitian comes in and provides comprehensive nutrition assessment. This is a more detailed assessment beyond the SGA, which identifies physical exam, anthropometry, dietary and clinical factors that may impact food intake, as well as potentially biochemical markers. Also, further identification of barriers, such as doing a swollen evaluation, for example, or looking at a standardized test for depression. All of these could be barriers to food intake that need much more assessment and identification of how best to treat. So that requires a dietitian's involvement. All this leading, of course, to individual's diet and nutrition support prescription by the dietitian. So that's the basics of the impact, and that's the result of this consensus-based process. But you're probably thinking at this point, well, we need to monitor food intake and monitor barriers as part of this integrated nutrition pathway for acute care. And so we decided to also involve in this development process the identification, development, and testing of two tools that would help us to identify barriers and monitor food intake in acute care. So the first tool is a mealtime audit tool, and it's a two-page form that's completed by hospital staff. It's meant to document mealtime issues, challenges, and or barriers that patients might have. Part one is completed before and during a meal. It talks about the general ward environment, the readiness for the meal. It describes the data, so it can be referred to in terms of what was going on in the unit, what day it was, for example, what unit, etc. Part two is completed with selected patients after the meal and identifies through interview with the patient what barriers they experienced. And a no indicates that the barriers was experienced by a patient. And the total is summed to come up with a total score, and we get a sense of overall the barriers that patient had, and on that unit for that day, the patients that were assessed in terms of mealtime audit tool, the overarching barriers that were seen. So how do we go about testing this and developing and testing this tool? Initially, it was based on the barriers we identified from our patient survey in the Nutrition Care in Canadian Hospital study, but also the various literature that's out there that talked about the challenges that patients ran into and how it was overcome through protected mealtimes and other interventions that had been put in place in other jurisdictions. So from that, we developed a draft tool, and we worked with a small clinician group and two HQP, Jimmy McCullough and Elizabeth Desnever, worked on this in detail in terms of developing the tool and working with clinicians to finalize the question items that we would include. We then went through two studies. The first study to just look at usability of this draft tool and was it easy to complete with older adult patients. And so we had 120 patients in 4 sites, and they were all over the age of 65 years, and we had 6 auditors completing the tool in those 4 sites. And we got feedback from those auditors and looked at the descriptive data as well to see how we needed to change the tool. We then made modifications and did an inter-rater reliability study in study 2. We took one site and 90 patients over 30 meals with 2 auditors to determine the inter-rater reliability. What that means is, do we see the same barriers being identified when 2 auditors go to the same patient at different times shortly after the meal, and are they basically getting the same information from that patient? So this is the first page of the mealtime audit tool. You can see it's just descriptive information about what meal it was, what unit, time the meal truck was delivered and distributed, etc. This is page 2, and I know it's quite hard to see. It's a little bit fine, the font, unfortunately, but basically it lists 17 items which are potential barriers to food intake during the meal that a patient may have experienced. And the auditor would basically ask the patient, did the meal come at an appropriate time for you? Yes or no, and no indicating that the barrier was experienced. This can be summed, as you can see, a total of no responses to get a total score for that patient. And you can do this, as I say, for several patients at a meal. In terms of reliability testing results, or reliability and descriptive results, from study 1, we found that on average in those 4 sites that completed this with 120 patients, 120 patients, on average there were 3 barriers experienced by the patients. Each site had different barriers being identified. So for example, some sites identified a high proportion with poor food temperature in terms of the hotness of the meal, whereas others had more interruptions by staff during the meal. So this was telling us that the mealtime audit tool was differentiating different practices in these 4 sites. The common barriers that we saw across the 4 sites, so experienced by more than 10% of patients, were temperature, and specifically hot temperature for the food, packages not being opened, the food not being appetizing, being disturbed at the meal, not having a mid-meal check, no alternatives being suggested when the patient did not like the food, and no snacks being offered for the patient either. So we refined the tool after study 1 was done. We spoke to the auditors about what were the questions that were challenging. The auditors also actually asked the patients how things went in terms of question wording for us, and that helped us to refine these questions. We then took that refined version into study 2 and did the inter-rater reliability testing. And the reliability was looked at based on the total score, and we did something called an inter-class correlation and identified that it was on average 0.68, which is pretty good reliability between the 2 assessors. And the confidence interval there you can see is from 0.52 to 0.79, which means good to very good agreement. Additionally, we looked at what was called concordance between the raters. So if rater or auditor 1 found an individual said yes, did the second auditor also have the same patient saying yes for that item? And we found that only 4 of 18 items had less than 90% concordance across the 90 patients. So we had good confidence that there was inter-rater reliability with the MAT tool. So now I want to briefly describe the My Meal Intake tool and where we're going with next steps with this data. So as clinicians in the field, you're probably thinking, how are we going to monitor food intake for many patients who are either on standard care once a week or twice a week, or for those patients that are on what we call level B or advanced care once a day? We need to have some simple tool that can do this. We can't rely on staff charting all of that detailed data on food intake. And so we knew from the Nutrition Care and Community Hospital study that in our 1,000 patients, a good proportion of them could self-report at a single meal what their food intake was like. And so we thought this would be the mechanism that we could start with and try for many patients. It might work. Obviously, patients with delirium and dementia, this would not work. But for many adult patients in acute care, this was potentially a viable mechanism for food monitoring. So we decided to develop this single meal intake record that could also capture some common food access issues at that meal for the patient, help us understand why they didn't eat as well at that single meal, and determine if it could be considered valid when compared to an auditor who looked at the tray. Again, we consider this a minimum for monitoring oral intake in a hospital. It would not replace our traditional calorie counts where we need more detailed information from patients about how they're doing in terms of energy and protein intake, for example. So how was it developed? We first looked to other simple one-meal tools, and specifically the Nutrition Day food intake form that we used in our nutrition care and Canadian hospital study was a key basis. But also there were other tools out there that have been used by others in long-term care as well as in acute care. So we looked at those tools and looked at what we thought were relevant bits and pieces. We used, again, the same clinician group and investigator group to help define and refine that tool. And then we went about testing it in the same 120 patients that we did the mealtime audit tool. We were looking for the validity as well as ease of completion of this tool. Choosing people that were already over the age of 65, we were also anticipating that this group, if any group of adult patients was going to have a challenge with filling out the meal intake tool, it would be older adults. Of course, our eligibility criteria required that these people could speak English or French, and they did not have delirium or dementia, and could be able to write and be able to communicate fully for this data collection. We were interested in the accuracy of the patient's estimation as compared to an auditor's recording of that food and fluid intake, and the auditors were all dietitians who were trained on estimation of food intake. So this is what the My Meal Intake tool looks like. So you can see that the patient can put in their name and their room number. There's some detailed instructions for them in a larger font, and then they're asked to fill in what meal this was and then fluids and solids in terms of food intake. So this is the final tool you're seeing. We actually went through a couple of iterations to get it to this point. And on the second page of the tool, or the back side of this tool, it identifies if their appetite was not as good as they anticipated, why their appetite was less than usual. That might explain the low food intake on the prior page, as well as any challenges they had to completion of that meal. We also identify in the form other comments, as well as who completed this form, the patient, family, friend, or volunteer, and or staff. In our data collection, it was all patients themselves that completed this data collection. So in our validation study of the My Meal Intake tool, almost 60% were female, almost 50% were over the age of 80 years, and 63% had at least a high school education. We found that almost 80% completed the My Meal Intake tool without error, so no blanks. They weren't skipping items. They completed the first page, which was our report that we wanted to make sure was valid in comparison to the auditor, well. In terms of that solid food intakes, that item on the bottom of the first page, we found a sensitivity of 76% and a specificity of 74% when compared to the auditor, and using a cut point of 50% or more, or 50% less than 50% of the meal that was offered. For fluid intake, overall, we summed it based on what the patient said, all of the fluids they consumed, and categorized it as greater than or equal to 50% of the fluids being consumed or less than 50% of the fluids being consumed. And this was compared to the auditor who did the same, and we summed it and categorized it similarly. We had a slightly lower sensitivity here, but we found that when we looked at individual items on that listing of beverages like milk, coffee, juices, that it was actually a higher sensitivity than the overall total fluids. And we think what happened here is that patients often would write on water, which they had from their jugs or from water that was delivered by other staff and not on their tray, whereas the dietitian staff, who were the auditors and looking at the estimation, did not include water on their estimations. We found that males, those that were less than 80 years of age, those with less than a high school education, and those with a better appetite had better accuracy with the My Meal Intake tool for solids and fluids. We, though, couldn't do statistical tests on this because of some of the small cell sizes that we had. 45% of those with a low appetite also had low intake, versus 6% had good appetite and low intake. So this confirms for us that low intake was associated and with low appetite, which gives us a bit of what we consider construct validation as well of this tool. So you're probably thinking, though, we've got these great tools out here, and I know I have to wrap up, we're getting close on time, but you're probably wondering, is IMPACT even feasible? What resources are going to be required to implement this pathway? Will it improve our care processes? Will it improve patient-reported outcomes such as the mealtime audit tool and the meal intake tool for patients? And how can it be implicated, and what are the better practices to support implementation? Well, that's exactly where we're at. We identified, just to show you the flow of data collection, we've done the integrated nutrition pathway for acute care development, and we've done the development of tools that support the integrated nutrition pathway for acute care. We're now actually in a phase of testing out those exact questions. Can More to Eat be a study that implements IMPACT, and can we watch how 5 very different sites do that? We were fortunate to receive a SIG grant in 2015 to do this testing, and we're right now moving forward with that data collection. So the objectives of this study are to develop an implementation program for IMPACT, to test and evaluate the implementation in 5 very diverse hospitals in 4 provinces, and we also have a sub-study looking at a high-energy protein supplement in a subgroup that are frail. I won't speak to that more at this point in time. We're following a knowledge to action process. I, again, won't go through this in detail, but we're following the principles based on knowledge to action to make sure that we're implementing IMPACT and hopefully thus sustaining IMPACT because of this process. The More to Eat project is very complex, and I won't go through it in detail here for you, but we are right now what we call the implementation phase. So we spent the first part of our data collection in terms of baseline data collection, creating materials for site, and helping our sites develop change practices and training on those change activities. We had a stakeholder meeting in December to help the sites and move forward in terms of change activities, and now we're actually doing the implementation process using a quality improvement framework and other behavior change mechanisms. So where are we going beyond the More to Eat project? With our IMPACT and with our 2 tools that we've developed, we've disseminated them in terms of open access. So the IMPACT is published in an open access journal, and we're going to be positioning the 2 clinical tools into clinical practice journals. Those are actually part of a graduate thesis by Jimmy McCullough, and he'll be defending that hopefully in the next few months, and those 2 papers are in draft form and are going to be submitted very soon to journals. We also are presenting this work at national and international conferences and have had been involved in international expert discussions, most recently at the American Society for Parental and Enteral Nutrition this past January in Austin, Texas, and hopefully having a similar discussion at the Canadian Nutrition Society meeting in May of this year, with some experts that are international coming to a symposia to talk about best practices with implementation of nutrition screening and diagnosis in acute care, and then finally doing some work hopefully in the European context at the European Society for Parental and Enteral Nutrition this fall as well. All of these tools are already available on the CMTF website, and there's guidance documents for both the IMPACT and the clinical tools, the My Meal Intake tool and the Mealtime Audit tool, and they're there for you to use in PDF form with the guidance documents to help you in terms of making sure you do it in a quality manner. We also have a variety of CMTF and CNS, Canadian Nutrition Society newsletters that have been publishing this work and getting the news out about the various tools that we've created as a result of Nutrition Care and Canadian Hospital study. And finally, we're working towards advocacy with regional, provincial, and national decision makers. For example, the ministers of health and local governments, thinking about trying to get them to understand the importance of quality nutrition care practices and using the IMPACT as a speaking point to how nutrition care can be provided in acute care in a more systematic, standardized way that is going to meet the needs of our patients in Canada. So some take-home messages for you today. Improvements in hospital nutrition care are definitely needed based on our nutrition care and Canadian hospital study. We're not meeting the needs of malnourished patients coming into acute care, and there are many barriers to food intake that are leading to further poor food intake in hospital. Impact was designed to be feasible and practicable. We knew that we could not assess every single patient that was identified to be at risk with screening and had to do some form of triage, which we're doing with the subjective global assessment. We're testing that out with our More to Eat project, and hopefully we'll find that it is feasible. Staff, hospital management, professional associations, government all have a role to play in this issue, and we need to gather together these efforts from a variety of sectors to make change in nutrition care. The My Meal Intake tool and the Mealtime Audit tool are quality tools that can be available for auditing practice and helping sites and units to make change. And so we encourage people to start using these tools now, even if they're not necessarily rolling out Impact, to promote better practices in their acute care units. And finally, we're hoping that the More to Eat study will test the feasibility of Impact and implementation and will provide us with high quality information to help others implement the Impact in the future. So just some key acknowledgements. We have a large team, so Jimmy McCullough, Elizabeth Desnever, and Celia Lior, who are HQP involved in this project, have been instrumental in getting this work to this stage. Hannah Marcus, a dietitian at Grand River Hospital, who's involved intimately with the inter-array reliability testing of the Mealtime Audit tool. All of the co-investigators on the Technology Evaluation for the Elderly Network Catalyst Grant, of course our funding from TVN, and a variety of collaborators are involved that help to make this work possible. So thank you very much.
Okay, thank you, Heather, for that very informative presentation. We do have quite a few questions from our audience, and we'll try to get as many as possible. There is one very long one. I will feed it to you near the end. I think we have maybe 7 minutes to do some questions. So a few questions have come up on basically, are one of these sites rural?
Sorry?
Are one of these sites rural?
Oh, the More to Eat sites.
Uh-huh.
No, we do not have a rural site. We chose hospitals using an RFP process. We wanted hospitals that we knew had made contact with the Canadian Malnutrition Task Force, had a lot of interest in changing practices, so it was a key piece, but also they had to demonstrate organizational capacity. And so we invited people to put forward an RFP process because our timelines for granting were very short for the TVN grant. And so that's the route we took. So no, we do not have a rural hospital, but we did seek diversity in our hospitals. We have 2 regional hospitals. One would not be considered a high-level acute care. 2 of them are, I should say 3 of them are academic centers. One makes their own food, for example, and we wanted, again, diversity in terms of region. That was more relevant to us than a rural-urban mix. We didn't have enough money to do lots of hospitals. We only could pick 5, unfortunately.
Yeah, TVN didn't give you enough money. And another question came up, and it's about training. They said, you mentioned that the CMTF will provide training for anyone wanting to learn how to do the physical assessment part of the SGA.
That's correct.
Could you elaborate on that?
Certainly, and so we've developed over the last couple of years the process, and so please contact Bridget Davidson, who is the Executive Director for CMTF. What we encourage sites to do is, first off, get the video that is provided online that you can purchase for your site and use the video as an initial education piece, and then Bridget Davidson can come in and help you with the hands-on piece using your own patients. There's some steps you have to go through, obviously, in terms of making sure that's okay with your hospital for her to come in and to assist you with that. We found that that is a good model for developing skills. And at this point, we're able to meet the need of hospitals. If the need is overwhelming, we will have to think about perhaps getting regional leaders trained who can then train others. So sort of more of a train the trainer sort of approach.
Okay. Yeah, a few have commented that, you know, what is the community malnutrition plan going forward, and basically how do you have diversity without addressing rural? So,
well, we chose other reasons for diversity, let's just say that, and so we looked for academic, non-academic, regional hospitals versus urban center hospitals, etc. And again, variety in the way that they were planning to undertake impact. So that was more our concern, not as much as the role. Unfortunately, I agree we're not getting that piece. So in terms of the community piece, though, certainly that's a next step that we know we need to move to in terms of research. And part of our data collection for More to Eat is actually doing some post-hospital data collection with patients as well at baseline, partway through the implementation phase. And at the end of the implementation phase, we're picking up a subset of patients to talk about their experience post-discharge from hospital and getting more detailed data collection from them. We also know from the Nutrition Care and Canadian Hospital study that that group is at risk, and so looking for opportunities to think about next steps with research around implementing screening post-hospitalization with primary care providers, for example, home care, community agencies, etc. So that's an opportunity we're looking forward to.
Okay, great. A few questions have come in basically to ask, how do you measure impact?
Impact of impact, or so good question. So in terms of the what we're interested in measuring, what are the key things we're looking at is, so if I go back to just the impact slide so you can see it, what we're actually looking at in our implementation phase, a big piece of it, is looking at from baseline where 3 of the 4 sites did not have screening at all at baseline. And we wanted sites who had already started with screening and some who had not done screening at all. What we're looking for is as sites are moving forward in implementing these factors, are they starting these various activities? So for example, one site had no screening done by staff at baseline. And over the implementation phase of our 1 year of implementation, they're doing training with their site staff. They've designated a role to a specific group within their staff to do screening. And we're tracking every month the charts of patients that have been admitted on a single day, looking at, are these activities happening? So are they doing and looking for barriers to food intake, for example? Are they screening and then triaging using subjective assessment, etc.? So we're looking for basically the fidelity to impact. Are these activities happening over time? That's the key way we're understanding if impact is being implemented in the way we anticipate. In addition to that, we're collecting a lot of qualitative information from the sites through monthly teleconferences, scorecard documentation to track the process that they're undertaking to implement these various activities.
Okay. Heather, because we're running out of time, a few people have asked if you would be open to giving out your email for further questions, as we won't be able to cover them all today.
Absolutely.
Okay, so we'll post your email on our website. I'm not sure if it's on one of your slides that we could show right now.
Might be at the very beginning. Maybe not, though.
Okay. We'll post that if it's not in your slide, and people are asking if this is going to be posted on our website, and yes it is. It will be posted probably early next week. As I said earlier, we're transitioning to our new name of Canadian Frailty Network, and as we're doing this, there's a lot of work in the background that has to be done, so we've kind of frozen our website for the next few days, and so it will be up next week. If somebody has some questions, we have an opportunity maybe to give out your email to the ones that have requested here by using the GoToWebinar. So I think we're getting close to 1 o'clock. So in conclusion, I was kind of nervous about this webinar at the beginning because I'm working off a new laptop, but it went very well. And thank you, Heather, for your presentation and sharing your results today. As I said, you have a lot of questions coming in that we all can't answer, and quite a few people have asked me to congratulate you on your great presentation. So, so yes, we really appreciate it. And thank you for sending in your questions and attending today's webinar. And I hope you can join us for our next webinar on March 2nd. And I have the webinar page up now, and so we're also hoping that you will take the time to do the brief survey that will come up in the next few minutes so we can improve the webinars. And I guess again, thanks Heather for doing this. I will share your email, and everyone please have a good day despite the weather challenges in central and eastern Canada. And that's it for today. Thanks so much for coming on today. And thanks, Heather.
Thank you. Bye-bye.
Okay, bye-bye.